one of the most important part of your clinical learning, that is estimation of ABG, how to interpret and how to collect the sample for ABG. ABG, that means arterial blood gas, right? So the name itself signifies that artery, the blood is collected from the artery, right? And so after collecting the blood, the sample is processed to see the gaseous structure, right? So this is ABG analysis. Okay. So as I have already mentioned, this is ABG, arterial. Side by side, there is also another blood gas estimation, that is VBG, that is venous blood gas estimation. But we prefer ABG over VBG. Why? Because we all know that if there is venous blood, in venous blood, there is slightly increased number of carbon dioxide concentration, right? And slightly decreased oxygen concentration. So actually that hampers the ideal scenario of your blood or of your body, right? So ABG definitely is preferable over VBG, venous blood gas. But actually it's difficult to collect arterial blood gas more often when you try to collect the blood from artery. Initially যখন প্রথমে তোরা করতে যাবি তখন definitely there will be some venous admixture of the blood with the arterial blood. Okay, so now if you wrongly collect the venous blood and you did an VBG, so from VBG, yes, you can also estimate ABG. So the difference of carbon dioxide in VBG and between VBG and ABG is around 3 to 5, right? And in case of pH, the pH of VBG blood is generally 0.03 higher than the ABG blood. Okay, because of the carbon dioxide level, right? So this is venous and this is lower than the ABG. So this is venous and this is ABG. So we try to do ABG, but definitely during your initial practice, initial day, there may be admixture of venous and arterial blood. So what are the indications of doing an ABG? Definitely that is to measure the acid-base balance. This is very important part. To determine oxygenation, so there is another one, and during the ventilation period, if the patient is in ventilator or if the patient is in non-invasive ventilator or in invasive ventilator, then arterial blood gas estimation definitely is useful to detect that ventilation is adequate to compensate the primary acid-base balance, right? Next one, definitely artery. What are the mostly used arteries to estimate ABG? Radial artery and femoral artery. These two are the mostly used. But we prefer radial artery over femoral artery. Why? Because radial artery is superficial one. Second, it is supported by a bony structure, and the radial artery supplies the palmar arch, right? So there is another collateral circulation to the palmar arch except from the radial artery, that is ulnar artery. So if by any chance you puncture radial artery and the radial artery got thrombosed, there will be no blood circulation through the radial artery. Nothing to worry. There is another artery, that is ulnar artery, that supports the palmar arch, but there is no as such collateral circulation in other areas. So radial artery is the useful one, and definitely femoral artery is easier to access than the radial artery, because the bore of the femoral artery is more wide. But the problem with the femoral artery is chance of infection. The groin area definitely there is always chance of infection if you prick in the groin area, right? So prefer radial artery over femoral artery. So what are the prerequisites of doing an ABG? Before doing an ABG, first, pre-heparinized the syringe. Look at the term pre-heparinized. I am not saying that draw heparin but the correct way is draw heparin just 1 ml and flush it out. Okay. Why? Because if you pour more heparin into the syringe and if you estimate in your ABG with your ABG blood, then there will be decreased pH, because heparin is acidic. Okay. So always heparinize the syringe, not fill the syringe with the heparin. Second one is free the air bubble. Why? Because if there are more number of air bubbles inside your ABG syringe, that may result in erroneous estimation of partial pressure of oxygen. Okay? Always free the air bubble. Next one is definitely avoid venous mixture. কিভাবে assess করবি whether this is a arterial blood or this is a venous blood? First, look at the color of the blood. Color of the arterial blood is bright red, whether the venous blood is dark red type, right? Second one, the arterial blood actually যখন তুই ইনসার্ট করছিস ABG syringe through the radial artery, then you can feel the pulse of the radial artery. So pulsatile flow of the radial artery blood through your ABG syringe will be there. So this is another marker of arterial blood. Okay. Next one is, this is also an important one, that do not delay in estimation of ABG after drawing the blood, because that can also actually, if you delay the process of ABG, doing an ABG, then it will hamper the estimation of pH, because it will decrease or increase the number of H plus in your blood. Okay, so that can hamper pH estimation. So always it's preferable to put the whole ABG syringe into an ice pack. If you do that, then ABG estimation, you can do ABG estimation even within 1 hour. And in non-iced pack container, if you put the syringe, then do ABG estimation within 15 minutes. This will be the correct timing. And this is also important, if severe hyper or hypothermia, then that also, we all know that hyper or hypothermia also disturbs our acid base balance. The H plus and bicarbonate ion actually get, the distribution of H plus and bicarbonate gets disturbed by the temperature change, right? So when you see your, তোরা কোনোদিন ABG chart, ABG দেখেছিস? ABG কোনো chart দেখেছিস? You have never seen any ABG chart, right? Okay, so in every ABG slip or ABG chart, at the uppermost part of the ABG, the most important thing to mention is this temperature. Okay, every ABG chart কিন্তু uppermost পার্টে একটা এরিয়া থাকে যেখানে টেম্পারেচার লেখা থাকে, যে ABG collected at this temperature. This is very important. So what will be the procedure? as I have already mentioned that the radial artery is the most ideal one from where you can collect the ABG. Okay, so যেটা আমি একটু আগে বললাম, why? Because there is an collateral circulation. Okay, so before doing a procedure you have to check whether the collateral circulation with the ulnar artery is patent or not, right? Because suppose ulnar artery is not patent and if you puncture the radial artery and radial artery got thrombosed, then the catastrophe will happen, right? Right? The palmar area will not get enough blood supply and it will be actually it will form gangrene, and the arm, the palmar area, actually from the wrist area, even the worst may happen that amputation will occur, right? So always check for the collateral circulation with the ulnar artery, that is patent or not. So how to do that? The test that is called as modified Allen test. Konodin শুনেছিস? Have you heard about this modified Allen test? So how to do that? Any idea? How to do that? First, ask the patient to clench the fist. Okay? Clench the fist, and this is the radial and this is the ulnar artery. Compress the both arteries simultaneously. Okay? For few seconds. Unclench the fist. কি হবে তখন? There will be blanching. তাই তো, ব্ল্যাঞ্চিং হবে। ব্ল্যাঞ্চিং মানে there is no blood supply into the palmar area, so there will be blanching. Then slowly release one finger from the radial artery. This is the radial artery, so slowly release. Okay? তারপর কি হবে? If within few seconds, within 10 to 15 seconds, the palmar area the color of the palmar area will be back to normal. Understood? If the ulnar artery is patent, then the blood will go through the ulnar artery, bypassing the radial artery, and supplies the palmar area. And the palmar area will be red, right? So this is the modified Allen test, and do it with the ulnar artery, radial artery one and ulnar artery. So আবার একবার ক্লেঞ্চ করতে হবে, তারপর দুটো আর্টারি একসঙ্গে প্রেস করতে হবে। একবার ফার্স্টে আলনার আর্টারি তোলার, আলনার আর্টারি থেকে ফিঙ্গার তুলবি, রেডিয়াল আর্টারি দিয়ে দেখবি আসছে কিনা, আবার সাইমাটারি রেডিয়াল আর্টারি তুলে আলনার আর্টারি দিয়ে কোলাটারাল সার্কুলেশন দেখতে হবে। This is the important, very important test. Okay, this is the picture. Clenching of the fist, pressing both arteries simultaneously and releasing one by one. So a negative Allen test, that means you can do ABG safely. You can take the ABG from the radial artery safely. Now, if the Allen test is negative, that means you can proceed. So what will be the procedure of doing an ABG? ABG কখনো কেউ করেছে দেখেছিস? What is the procedure of doing an ABG? Okay, so first palpate the artery and hold the wrist at the extended position, right? So hold the wrist at extended position, and after palpation of the artery কি করতে হবে? You have to support the wrist with a solid thing, right? Any actually আমরা কি করি, একটা NS বা নরমাল স্যালাইনের বোতল দিয়ে ওটাকে এক্সটেন্ড করে রাখি, হাতটাকে এরকম করে এক্সটেন্ড করতে হবে, রাইট? সো দ্য palpation of the radial artery and access of the radial artery will be much more easier. Okay, then তারপর কি করতে হবে? Hold the syringe at 30 to 40 degree angle, এরকম ভাবে ঢোকাতে হবে, ঠিক আছে? রিস্ট এখানে একটা সাপোর্ট, এটা palpation হলো radial artery. Just insert your needle at the 30 or 40 degree angle. Okay, slowly insert the needle and applying the negative pressure. যখন the first gush of blood will appear inside your needle, inside your syringe, after sudden loss of resistance, just insert করতে করতে দেখবি sudden there is a sudden loss of resistance and gushing of blood, red blood. So that is arterial blood. Okay, অনেক সময় প্রেসার যদি অনেক বেশি থাকে পেশেন্টের, তাহলে you can feel the pulse also, pulsatile nature. Okay, so and always this is very important before doing any surgical procedure. Always clean the site, and this is already you know from your surgery class. Now this is the ABG chart, right? So দেখ কি বলেছিলাম, basically first the identification, patient number or patient name will be there, patient ID, anything, operator name, and this is very important, temperature is been mentioned, right? 37 degree. FiO2, this is also important. In every ABG estimation chart, FiO2, that is fraction of inspired oxygen, will be mentioned. Why this is important? Because this patient, the ABG যখন নেওয়া হয়েছে পেশেন্টের, তখন patient was on 4 liter of oxygen, right? So if you are giving the patient 4 liter of oxygen or 5 liter of oxygen, then definitely PO2 will rise. When a patient is in room air, compared to in those patients getting oxygen, the PO2 definitely will rise, right? So there will be erroneous in measurement if you not mention the FiO2 or liters of oxygen, right? So next one is pH and এই প্যারামিটারস গুলো খুব ইম্পর্টেন্ট, pH, PCO2 and PO2. These are the primary parameters of ABG. So what are the components? First one is pH, that means that measures the acidity or alkalinity, right? So the normal pH is between 7.35 to 7.45. So less than 7.35, this is termed as acidosis, and more than 7.45, that is alkalosis. Then PO2, that means this is correctly, it should be termed as PaO2, small a, P small a O2. That means partial pressure of arterial oxygen. And when you measure VBG, that is PVO2, partial pressure of venous oxygen, right? So this is PaO2. And next one is PaCO2 or PCO2, you can call, the partial pressure of arterial carbon dioxide. Now the next thing is bicarbonate, because bicarbonate is the strongest buffer, you all know that from your biochemistry class. So bicarbonate determines, bicarbonate, carbon dioxide, these both things are actually the determining factor of your pH, right? So bicarbonate is very important one. So normal bicarbonate is between 22 to 26. This is the range of bicarbonate. So next one is, what is this? This is HCT, that means hematocrit value, and hemoglobin value is also there. You can measure hemoglobin and hematocrit from ABG. What is this? This is SO2 or SaO2. So I have already mentioned about PaO2, that means partial pressure of oxygen, and this is the saturation of arterial oxygen, saturation, SaO2. Okay, so this is why this is important, because if you wrongly if you have already wrongly drawn the VBG, venous blood, then কি করে বুঝবি যে whether this is a correct ABG or this is a VBG? So by estimating the SaO2, if this is an arterial blood ABG, then the SaO2 will be just as similar as that of your SpO2, that is seen in pulse oximeter. Patient এর pulse oximeter লাগানো আছে, সেখানে suppose the saturation is 95%, okay, and suppose your SaO2, that means in ABG, is showing the saturation of 92. That means quite similar, 3 to 5 gap of 3 to 5. That means yes, you are correctly doing an ABG. But if the SpO2 is showing as 95 and your SaO2, that is this one, is showing 64, that means this is venous blood, this is not the arterial one. Clearly understood? এখান থেকে বোঝা যায় যে কিভাবে arterial and venous blood কে differentiate করা যায়. Next one, these electrolytes, that means sodium, potassium and ionized calcium can be measured. But definitely sodium, potassium, basically this is not the ideal one to get the value of sodium, potassium. The peripheral blood estimation is the ideal one, right? But in your emergency setting, in your emergency ICU, when you are getting a patient with at the severe gasping state or severe metabolic acidosis, then sodium potassium estimation definitely may help, right? But the ideal value does not always match with the normal blood values. ঠিক আছে, basically potassium value of potassium change করে অনেক কিছু প্যারামিটারের উপর. How you are drawing the blood, you are using the tourniquet or not, right? So these things, and if you heparinize the blood more than that is needed, actually these all things may falsely actually hinders the sodium potassium balance, right? So sodium potassium estimation is important from your ABG, but don't blindly rely on that. Side by side, always send the blood for sodium potassium. And next one is bicarbonate, as I have already mentioned that, and base excess. This is also important. Base excess, the name itself implies base excess. That means how much base is excess in your blood, right? So base excess ranges from the -2 to +2, right? Whether it is acidosis or alkalosis. And next one is ST bicarbonate or T bicarbonate. That means standard bicarbonate. What is that? Actually, the amount of bicarbonate that is needed to restore the pH at the normal level. This is called a standard bicarbonate. Suppose the pH is 7.1 or 7.2, pH is low, and definitely bicarbonate লেভেলটা হয়তো লো আছে, বাট এটা নর্মাল এখন আছে, বাট কতটা বাইকার্বনেট দিলে the pH will be at normal range, that is called standard bicarbonate, STCO bicarbonate. TCO2, that means total carbon dioxide in body, that in other forms, not only HCO3, not only bicarbonate, but other physical solutions, other carbonate anion, all the carbonate anions and bicarbonate cumulatively, actually যখন আমরা কাউন্টার করি, that is called as TCO2. সবকটা কার্বন anion, সেটা হচ্ছে TCO2 measurement. Now regarding the estimation of ABG, first one, look at the pH, whether this is acidosis or alkalosis. If the pH is less than 7.35, definitely this is a case of acidosis. More than 7.45, this is a case of alkalosis. So first look at the pH. Next one, look at the primary disorder. So what are the 4 primary disorders? Metabolic acidosis, metabolic alkalosis, respiratory acidosis and respiratory alkalosis. So metabolic acidosis compensated by respiratory alkalosis, metabolic alkalosis by respiratory acidosis, respiratory acidosis by metabolic alkalosis and respiratory alkalosis by metabolic acidosis. So these are the compensations. The primary disorder are the 4, 2 metabolic and 2 respiratory. So what is the primary disorder? Actually এটা একটা খুব ইজি ডিকটাম. So if all the arrows are at the same range, same direction, that means pH is low, PCO2 is low and bicarbonate is low. That is same direction, pH low, PCO2 low and bicarbonate low. That is primary is metabolic. At same direction এ যখন arrow যাবে, that means the primary is metabolic. pH high, PCO2 high, bicarbonate high, that is also primary is metabolic. Metabolic alkalosis definitely. ঠিক আছে? আর যখন opposite direction এ যাবে, that means the primary is respiratory. pH low, PCO2 high, bicarbonate high, that means this is respiratory. pH high, PCO2 low, respiratory. এটা কিন্তু এটা ক্লিয়ারলি আন্ডারস্টুড না এটা, বিকজ দিস ইজ ভেরি ইম্পর্টেন্ট. যদি তোরা প্রাইমারি ডিসঅর্ডার আইডেন্টিফাই না করতে পারিস তাহলে there is no point of estimating the compensation, right? Next one is if the blood gas is compensated or not, and fourth one is anion gap, but anion gap if the patient is having metabolic acidosis only, not in other areas. Now one by one, PaO2. Let's discuss about PaO2. That means partial pressure of arterial oxygen. Okay. So the normal value is around 60 to 80 millimeter of mercury. Less than 60 is called hypoxia. So we all know that there is an alveoarteriolar gradient, right? Alveocapillary gradient at the alveolar level, where from the alveoli the oxygen is diffused to the artery, and from the artery carbon dioxide will enter into the alveoli. So this is we all know. So if in any disease such as ARDS or pneumonia, the alveolo-capillary membrane is damaged, or at the area of alveolo-capillary at the membrane there is exudates and neutrophilic infiltration. তখন কি হবে? তখন alveolo-capillary membrane is damaged. There is loss of diffusion from the alveoli to the artery. ঠিক আছে? So alveoli gets oxygen, but it cannot be diffused to the artery. This is the reason there is a gradient that is called as capital A small a gradient, AA gradient. So the capital A denotes alveolar oxygen, arterial oxygen, alveolar oxygen, alveoli, and small a is arterial oxygen. That means PaO2 partial pressure of alveolar oxygen and P small ao2 partial pressure of arterial oxygen. The difference between the PaO2 and PaO2, this is the AA gradient. Right? Clear এখান থেকে? So AA gradient কি করে increase করবে? So normal AA gradient is around 12 to 16. This is the AA gradient. Suppose the alveoli gets oxygen, but the artery is not getting enough oxygen. In case of, as I have already mentioned, pneumonia or ARDS or pulmonary edema, heart failure, তখন diffusion হচ্ছে না. So the AA gradient will be higher. ঠিক? But when the alveocapillary membrane is intact, there is normal diffusion. but there is hypoxia. Suppose in case of high altitude, যখন তোরা high altitude যাবি তখন there is hypoventilation, right? So you are getting low oxygen itself from the atmosphere, but your arterial gradient is definitely normal because the membrane is intact, the diffusion is normal. So the AA gradient will be normal in that case. Morphine overdose, there is respiratory depression, but respiratory depression is there, but AA gradient will be normal. This is a very important MCQ also. Normal AA gradient and increased AA gradient. So the AA gradient PaO2, actually PaO2, alveolar oxygen, can be calculated by this formula. 150 minus PaCO2, arterial oxygen or arterial carbon dioxide, divided by respiratory quotient, that is 0.8. This is how you can measure the alveolar oxygen and subtract it from the arterial oxygen. You can easily avail the AA gradient. And next, very important one, to assess the PF ratio. This is also important. PF ratio, that means PaO2 FiO2 ratio. Suppose you are giving oxygen. What is FiO2? How to calculate FiO2? জানিস না? FiO2 কি করে ক্যালকুলেট করে? Any idea? There is a chart of calculating FiO2. 1 liter of oxygen, that means 4% of FiO2 increase হবে, right? Room air, in room air, আমরা যে room air এ আছি, so we are having 21% FiO2. That is baseline. 1 liter, 25%, 4 increase. 2 liter, 29%. 3 liter, 33%. এরকম ভাবে যায়, ঠিক আছে? 4 করে ইনক্রিজ হবে। দ্যাট মিনস সাপোজ তুই পেশেন্টকে 4 লিটার অফ অক্সিজেন দিচ্ছিস, বাট দ্য PaO2 is 55. That means the patient is in hypoxic state, less than 60 though. So you have to calculate the PF ratio. You are giving FiO2, you are giving enough oxygen, but the artery or the alveoli, it's not oxygenated properly. যেখানে diffusion problem হয় ARDS এ, এটা very important. PF gradient, PF ratio is very important. So এই PF ratio actually কি জন্য কাজে লাগে? আমাদের ARDS এর severity classification. According to the Berlin definition of ARDS, PF ratio, if the PF ratio is less than 300, less than 200 or less than 100, that is the severity of ARDS. Less than 300, that means that is mild, less than 200 moderate, and less than 100 is severe ARDS. So this is as per the Berlin definition. Okay. So next one is PaCO2. PaCO2, that means partial pressure of carbon dioxide. Predominantly কিভাবে PaCO2 determine হয়? By the alveolar ventilation. If there is alveolar hypoventilation, then the PaCO2 will rise. There will be carbon dioxide retention. Okay. So increased PaCO2, that means there is hypoventilation, whereas decreased PaCO2, that means hyperventilation, especially in case of anxiety disorder. যখন পেশেন্টের অ্যাংজাইটি ডিসঅর্ডার হয় তখন পেশেন্টস কি করে? হাইপার ভেন্টিলেট করে। দ্যাট লিডস টু কার্বন ডাইঅক্সাইড ওয়াশ আউট। দ্য PaCO2 falls below the level of 40. So there are 4 types of respiratory failures: type 1, type 2, type 3 and type 4. But according to the recent classification, there are 2 types, type 1 and type 2. So but তোদের জানতে হবে 4টে টাইপস: type 1, type 2, type 3, type 4. What is type 1? just hypoxic. Carbon dioxide is within normal range, but oxygen is below normal, less than 60. That means this is hypoxic respiratory failure or type 1 respiratory failure. Example of type 1 respiratory failure, anyone? Anyone? Example of type 1 respiratory failure. খুব most commonly কি? Pneumonia, ARDS, pulmonary edema, high altitude, এগুলো হচ্ছে type 1 respiratory failure cause. Second one is type 2 respiratory failure. That means increase of carbon dioxide more than 45 millimeter of mercury plus PO2 is less than 60 combination. This is called as type 2 respiratory failure. Most common cause of type 2 respiratory failure, that is obstructive airway disease, exacerbation of COPD, even asthma and bronchiectasis. That leads to hypoventilation. Right. Next one is if there is diaphragm palsy. Diaphragm palsy hole the patient hypoventilate korbe, retention of carbon dioxide will be there. Right. And respiratory depression. So respiratory depression, central respiratory depression, neuromuscular blockade. So these things are the important cause of type 2 respiratory failure. The next one is type 3 respiratory failure. So what is type 3? Type 3 is just as that of type 1, that is hypoxic, but that occurs post-operatively. মানে post-operative, after anesthesia complication or the lung collapse, তখন type 1 respiratory failure হয়, that is called type 3 respiratory failure. And type 4 respiratory failure, that means in sepsis, the respiratory failure develops in sepsis. So type 4 is just like type 2, type 3 just like type 1. So এই জন্য চারটে এখন ডিজলভ করে দেওয়া আছে, এখন জাস্ট দুটোই হচ্ছে আমাদের রেসপিরেটরি ফেলিওর, দ্যাট ইজ টাইপ 1 and type 2. So this is important, type 1, type 2, type 3 and type 4. Now buffers. So what are the important buffers? So আমি প্রাইমারি ডিসঅর্ডার এগুলো বললাম, এরপর let's discuss about the compensation. So before discussing compensation, you have to know about buffers. So what are the main buffers of acid base balance from your biochemistry class? Bicarbonate is the and what are the other buffers? Phosphate. Next, hemoglobin buffer. Next, protein buffer, and sometimes ammonia buffer also. So the most important one is bicarbonate buffer. So এই ইকুয়েশনটা তো যারা জানিস, H2 plus CO2, that means H2CO3 that dissolves into H plus and HCO3. Right. So this is the compensation. Bicarbonate, actually the compensation of bicarbonate primarily occurs through the kidney. So kidney reabsorbs bicarbonate or excretes bicarbonate depending upon the acid base change, and also the H plus ion. So primarily, predominantly, bicarbonate is controlled by kidney and CO2 is controlled by the lungs. So these are the two buffering areas. So this is the chemical buffer, you all know. After respiratory acidosis এর compensation কি? Metabolic alkalosis. So respiratory acidosis or respiratory alkalosis এর compensation হয় very rapidly, but metabolic compensation মানে acute respiratory acidosis এর compensation কিন্তু rapidly হয়, ঠিক আছে? metabolic এর compensation হতে টাইম লাগে, ঠিক আছে? because why? Because metabolic compensation bicarbonate থেকে হয়. So the excretion of bicarbonate or the reabsorption of bicarbonate occurs through the kidney, and it will take time because of the tubular reabsorption and cellular change. But carbon dioxide elimination and retention of carbon dioxide is doing easily, right? Because তুই ভেন্টিলেশন বাড়ালে কার্বন ডাইঅক্সাইড ওয়াশ আউট হবে, ভেন্টিলেশন কমালে রেসপিরেটরি রেট কমালে কার্বন ডাইঅক্সাইড রিটেন করবে। সো দিস ইজ ইম্পর্টেন্ট। So change in pH result in change in PCO2 occurs within minute, but change in pH due to bicarbonate change occurs within days. So in respiratory acidosis there is increased bicarbonate reabsorption inside the kidney, and the vice versa will happen at the time of respiratory alkalosis. And the compensation formula is very important. এটা কিন্তু ইম্পর্টেন্ট বিকজ পেশেন্টের কম্পেনসেশন হচ্ছে কিনা এই ফর্মুলা থেকে তোরা বুঝতে পারবি। সো ইন কেস অফ অ্যাকিউট রেসপিরেটরি অ্যাসিডোসিস অ্যান্ড ক্রনিক, এই চারটে চার্ট মনে রাখবি ইম্পর্টেন্ট, 1 2 4 5 1 4 2 5, রাইট? সো 1 4 2 5 acute chronic respiratory acidosis and respiratory alkalosis. That means what is 1? That means for every 10 increase of PCO2, the change of bicarbonate will be 1. Okay? Clear ekhan theke? Every 10 increase there is a change of bicarbonate of 1 in case of acute respiratory acidosis, and pH change will be decrease of 0.08. A 0.08 and 0.03 is similar. Duto group is similar but different in acute and chronic. But what is different? That is the level of bicarbonate. 10 in 1 in case of acute respiratory acidosis, 10 in 4 in case of chronic respiratory acidosis, 10 in 2 in case of acute respiratory alkalosis, and 10 in 5 in case of chronic respiratory alkalosis, right? So মেটাবলিক আমি পরে আসছি, আমি রেসপিরেটরিটা আগে পড়াই, তারপর মেটাবলিক। সো ইন কেস অফ অ্যাকিউট রেসপিরেটরি অ্যাসিডোসিস, ডেল্টা পিএইচ, দ্যাট মিনস চেঞ্জ অফ পিএইচ, পিএইচ কতটা চেঞ্জ হবে, দ্যাট ইজ ডিটারমিন বাই 0.08 ইন্টু PCO2, the delta PCO2 gap. Suppose PCO2 is 55, right? 55 is PCO2. তোরা বল কিরকম ভাবে হবে? Suppose the PCO2 is 55. So pH কি হবে, কি চেঞ্জ হবে? That means this is a respiratory acidosis, right? pH তার মানে কমবে, তাই তো? pH তো কমবে। So pH কত হবে? 0.08 into delta PCO2. 56 minus 40. So 0.08 into 16. That is the change of pH, right? So chronic respiratory acidosis, change of pH will be 0.03 into delta PCO2, the gap of PCO2. এটা কেন? This is very important because কোনো ABG তোকে হয়তো কোনো পেশেন্টের ABG তোকে দিল, রাইট? সো তোকে আগে ডিটারমিন করতে হবে whether this is acute or chronic, তারপর তো তুই কম্পেনসেশনে যাবে, বিকজ অ্যাকিউটের কম্পেনসেশন আলাদা হবে, ফর্মুলা ক্রনিকের আলাদা হবে। আগে তোকে পিএইচ ডিটারমিন করে দেখতে হবে whether this is a acute or chronic. This is the cause of respiratory acidosis, you all know. আমি তোকে বললাম যেটা respiratory acidosis এর কজ কি, most commonly the neuromuscular blockade and obstructive airway disease, and respiratory alkalosis এর কজ হচ্ছে most commonly hyperventilation, anxiety related issues, and sepsis, aspirin overdose, pregnancy, cirrhosis. So these are the cause of respiratory alkalosis. So this is the problem 1. বল এখান থেকে বল, জাস্ট এটা রেসপিরেটরি পার্ট থেকে হচ্ছে। The primary disorder, what is the primary disorder? This is acidosis or alkalosis? Acidosis. And primary disorder is respiratory. Why? Because the pH is low, PCO2 is high, so there is opposite direction. This is respiratory acidosis primarily. Now this is acute or chronic, calculate kor, 0.08 pH এ চেঞ্জ দেখ, delta pH is equal to 0.08 into delta PCO2, কত আসছে দেখ, that means 0.08 into 78 minus 40, 38, তাই তো? তাহলে কত আসছে দেখ, ক্যালকুলেট করে কত আসছে বল, 0.304, রাইট? সো 0.304 ডিক্রিজ হবে পিএইচ। সো পিএইচ ইজ আমাদের নর্মাল পিএইচ 7.35 মাইনাস 0.3 ধর, তাই তো? তখন অ্যারাউন্ড 7.0 to 7.1। এটা 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 বুঝতে পারছিস? আরেকবার ক্যালকুলেট কর। এটা খুব ক্লিয়ার করতে হবে, কারণ এইখান থেকে যদি তুই বুঝতে না পারিস তাহলে কিন্তু গোটা এবিজি কিচ্ছু বুঝতে পারবি না। ক্লিয়ার? এটা ক্লিয়ার? 0.08 into delta PCO2, that means the number will be minus pH minus 0.304, that means around 7.0 to 7.1, এটা হচ্ছে pH হওয়া উচিত if this is acute, and if this is a chronic তখন কি করতে হবে, 0.03 দিয়ে মাল্টিপ্লাই করতে হবে, that means it will be around 0.114, so the pH will be around 7.29. Clear এখান থেকে? So if this is a chronic acidosis, then the pH will be nearer about 7.29 to 7.3, and if this is a acute respiratory acidosis, the pH will be around 7.0 to 7.1. এখানে pH কত আছে? 7.1. So this is acute respiratory acidosis. Clear? This is very very important. এটা রেসপিরেটরি প্রবলেমে কিন্তু খুব ইম্পর্টেন্ট। So next, whether this is compensated or not. So in case of acute respiratory acidosis, what is the formula of compensation? In every 10 increase of PCO2 there will be 1, right? So calculate কর কত আসছে। So the change of PCO2 is 38, 78 minus 40, that is 38. So the change of bicarbonate will be 3.8, right? So the bicarbonate will be, the corrected bicarbonate কত হবে? যদি 3.8 চেঞ্জ হয় তাহলে বাইকার্বনেট কত হওয়া উচিত? কত হবে? Compensation কি করে হবে? This compensation will be in the form of metabolic alkalosis. That means the bicarbonate will be plus the 24 plus 3.8, that means 27.8. If there is a compensation, then the bicarbonate will be 27.8, but here the bicarbonate is 22. So this is finally কি হলো, এটা acute uncompensated respiratory acidosis. Clear? This is very important. আবার বল, যদি এখান থেকে আরো কোয়ারি থাকে এইটা কিন্তু বুঝতেই হবে, দিস ইজ ইম্পর্টেন্ট। চেঞ্জ অফ পিএইচ কত হবে যদি অ্যাকিউট হয়, যদি ক্রনিক হয়? PCO2 is 50, so the change is 10, right? হ্যাঁ, তাহলে এটা 0.08 into 10, তাহলে 0.8, তাই তো? তাহলে 0.8 চেঞ্জ হয়েছে নাকি 0.3 চেঞ্জ হয়েছে? কত চেঞ্জ হয়েছে? 0.3 বোধহয় কত হচ্ছে দেখ, ক্যালকুলেট করে। এটা ক্রনিকই হবে, ওই 0.3 চেঞ্জ হয়েছে। সো 0.3, that means this is a chronic. So this is chronic respiratory acidosis, whether this is compensated or not. In chronic কত? 1425 বলেছিলাম, that is 4. In 10 change of PCO2 there will be 4 change of bicarbonate. তাহলে কত হচ্ছে দেখ, bicarbonate কত হবে? 28 হবে, তাই তো? 24 plus 4 হবে 28, তাই এখানে 29 আছে। So this is compensated. This is compensated respiratory acidosis. Alkalosis, whether this is respiratory or metabolic? Respiratory, because the arrows are at the opposite direction. So this is respiratory alkalosis, whether this is compensated or not, acute or chronic, whether this is acute or chronic, same formula তো, 0.08 0.03। pH ক্যালকুলেট কর কত আসছে, কত হচ্ছে? acute and compensated or not. So respiratory alkalosis, that means there will be metabolic acidosis, bicarbonate will be lower than that of normal, তাই তো? So change of কত হচ্ছে 1425, তোরা বলেছিস this is a case of acute alkalosis, respiratory alkalosis, that means change of bicarbonate will be 2 in every 10 decrease of PCO2, কত হচ্ছে তাহলে? চেঞ্জ অফ PCO2 কত 10 তাহলে বাইকার্বনেট কত হওয়া উচিত? ডিক্রিজ করবে 2, 24 minus 2 22, this is 21, this is compensated, ঠিক আছে? So this is compensated respiratory alkalosis. Clear?